like this is going to be a nice discussion. I'm happy to stop during the talk. This is truly 10 years of work. Everything I want to talk about, please say, this is garbage, I don't believe you, this doesn't work, it's not my center. But I want to have an interaction because I think this is, I want to change the way people think. And I've been doing this for 10 years trying to do this. And I can tell you the first 5 years people laughed at me and pushed me off stage. And then suddenly this kind of change happened over time with our published literature. We're starting off actually with the obscure nerve blocks first. So I think this makes it more difficult for you guys. But I want to do a little intro, talk about where I came from, what our story is. And I'll let you guys tell me what you think. So I always put this slide up. This is working. Oh, sorry. 1 second. Yeah, I put the USB connector. So this is how I felt when I started my career. I would be like, well, we would have, and I can tell you this, 10 years ago, we would do hip. I worked at a center where we had a lot of hip fractures, and I wanted to do blocks in these patients. And people would just be like, what are you doing? Are you insane? Like, why would you want to do this? And I literally started publishing literature because they wouldn't let me do it in my center. Luckily, I moved, and I'm much happier. So I work in a great little hospital. It's Highland Hospital. It's an affiliate of University of California, San Francisco. What's amazing about this place is we get these really smart people, and we get these amazing ability to converse, talk, and try to do the right thing for the patient. The ethos is always to do the right thing. It's never about the FDA, my boss. It's about doing the right thing. And it kind of allows us to teach our residents from day one, from the start, that they're the best at what they do. They can question me at all times and change practice standards. And it's interesting is a lot of our research comes from these young residents who start off on day one with our chair of anesthesiology, with our chair of surgery, sitting in a room, learning blocks. Because then we get great data. And we actually think outside the box. So I can just tell you from just a simple experience. This is July 4th is a wonderful day in America. People walk around and blow each other's arms off with firecrackers. And so this is at, I think, midnight, July 4th. I came on 11 p.m., so this kind of came in right at that interval. We had 6 gentlemen that came in and blew their hands off. I think 4, actually. It's like 11 hands came off. I don't know if I'm the exact number. One of them actually blew his hands off while he was throwing firecrackers out of his car, and then ran into a pole. So he's a blunt trauma, and he blew his eye off. So he came in, I can't make this up, screaming with his hands like this, no eye, and a trauma activation. So it was a complete cluster. And you can imagine giving him 14 of Dilaudid or whatever, hydromorphine, or whatever drug you want, isn't going to take care of pain. My orthopedic resident comes downstairs and says, I can't examine this guy. I can't examine what to do with him. I don't know what to do. He's screaming. Do something. So we literally got a bucket of bupivacaine or Marcaine with one of my senior residents, locked on the arms. And the beauty of this was, we were able to actually get an exam, actually take care of the patient. Some of them became apneic because they'd gotten so much opioids up front that they actually stopped screaming and became hypoxic from nasal cannula, a little stimulation. The point being is that this is something that has changed the way that we practice. Our orthopedic residents request it before they come down to see the patient. Our surgeons request it before they come down and see patients. This came from the fact that we used to have a bunch of patients that would come in that were, we have a lot of heroin abuse in Oakland, California. I don't know if there's a lot of heroin in Australia. We had a ton of it. And they would come in with these large abscesses because they would get tired and they would just puncture themselves, have these huge abscesses. Putting them under procedural sedation to drain an abscess or go in the OR is a huge time sink, right? As an ER physician, to find a room, to get them placed there, get a good access, give them medication that they're not, you give them 10 of whatever, they still sit there and look at you, and they want more. So what's nice is we started blocking them. This is our lovely gentleman who's getting... Any pain, sir? No. So he's on his phone talking to his wife about ordering Chinese food. I can't make that up. While the surgeon is pulling about 300 to 200 cc's of pure material out of his arm. And it sounds like, well, big deal. Just go to the operating room. Big deal. Just go ahead and sedate this patient. Putting that guy down comfortably is impossible. You will give more drugs, and you'll be so scared, giving him ketamine, whatever you want to do. It's a lot of work. What's nice is now for abscesses, it is the protocol in our department for us to block them, surgery come downstairs, drain their abscess, keep them, or send them home. Not mind-shattering, but what it does is also gives them post-operative pain. This guy, after that block, sat there, ate his Chinese food, hung out with his wife, and didn't request 20 of diamonic. The beauty of this is I want to change your thought process about pain. And in doing so, I think we're going to talk about some interesting blocks. We started teaching this young UCSF researcher that came into us. She worked in Congo. She went out there and realized that there's all these patients that come in with wound dressing changes would scream. They would call it the crying room. They would literally call it the crying room because they would come in crying for the wound changes. She's like, why can't I teach, not doctors, but technicians, to do blocks? We have a little machine, we just block them, and then do their wound dressings, changes. 1,300, 1,400, 1,500 blocks later, the crying room is done, right? This is the kind of power I think we have when we stop defining ourselves and start just thinking about what we can do. And you can see these patients get great care with a little bit of body care. So we'll do some basics on blocks. And I'm sure there's some people here have some understanding of ultrasound guided nerve blocks. I'm sorry to reiterate some of this basic stuff, but if I don't, it's really confusing to move forward. Just the vernacular helps. So we'll just talk about some of the basic stuff. So again, I'm not an anesthesiologist. I'm not putting a catheter in somebody. I don't do it sterilely. A simple probe cover is fine. The key for me is I like these. We have these are very expensive. All it allows me to do is to check and pull back to make sure I don't have any blood in my syringe. Because the last thing I want to do is push a lipophilic molecule, such as bupivacaine, into the vasculature. If I do that, I can have some problems. So this is a really nice tool. You don't really need them, but they're very inexpensive and they really are very useful. You can look at the fact that I use various syringes and needles, excuse me. You can get block needles that are very inexpensive, or you can use simple spinal needles. I use them all the time. Also, some of these short needles work very well as well. I'm going to talk about some planar blocks, which is a different term than just a simple block, and I'll discuss this. And in that case, I commonly just get a 20 cc syringe. I attach that needle on top of it. I either have my resident, or I push, or my nurse push anesthetic and volume if I need. For planar blocks, you tend to put more volume. Normal saline plus an anesthetic. And we'll talk about that in a second. A couple terms that you should know before we move forward. In plane versus out of plane. In plane is when you're having the needle visualized all the way through. Does everybody see the needle here? This is a brachial plexus block that we're doing. And the beauty is you're able to visualize the needle all the way through. I like this technique for nerve blocks because it gives me an idea where the needle tip is at all times. This, I think, is a better starting block for beginners. If there's anything that I teach my residents when it comes to nerve blocks, is I get a simple gel block, I put the probe down, and I have them just needle, like figure out how to find that needle in different planes. Once you can find the needle at all times, and you can get that visualization, you can block anything. Your needle can block anything. Then you can go on my website, you can go on somebody else's website, you can go on whatever book and do the block. Because you guys are all smart enough to do that. That skill set is the key. This is the out-of-plane technique, which is a little bit more difficult. This is how you classically do central lines. I think this is much more difficult because you're not really seeing the needle at all times, but you're seeing the fluid that comes out from the needle. So it's a little more difficult. And I tend not to do this block unless I have a more senior provider. And just one last little topic. I want to talk about nerves ultrasound because it always confused me. I didn't understand the concept of anesthetics and nerves, and it kind of didn't make much sense to me. So what do nerves look like on ultrasound? And what are we trying to do? So here is the median nerve. We all have it in our forearm. There's that needle coming in. So here again, when I think about nerves, I don't think about the nerve. That makes no sense, but I'll explain what that means. when you look at the two muscle layers, this is your profundus, and this is your superficialis and your profundus, excuse me. They both have fascial planes. The fascial planes come together and smush the nerve, artery, and vein. You ever heard of necrotizing fasciitis, right? Once that infection gets into the fascial plane, it spreads. So the key for blocks is really not getting the fluid on the nerve, but to open this fascial plane. Because once you deposit fluid in the fascial plane, it will slowly go around the nerve. Does that make sense to everybody? That's the key point. And I say that with all honesty. Spending your entire time hitting the nerve is not going to do you very much. In each one are these little fascicles. If I blow that up, it looks like this. These are your tiny fascicles in here. This is your entire kind of functional nerve, right? The goal is to put fluid outside, far away from the nerve, not inside the fascicle. You can imagine if I put fluid right here and pushed very hard, that would cause problems. So here is my needle. You can see there's the fascial plane opening up. And there's my physician, I think too close, closer than I like, opening that space up with fluid. Does that make sense? The fluid will slowly, lipophilic, go into the nerve sheath, block propagation of nerve fibers. The goal is not to have this, right? The goal is not to the needle and puncture the nerve. Because you theoretically can get a peripheral nerve injury. Very rare, but can happen. So I tell all my providers, stay away from the nerve. You see here, if you push in there and you put pressure in that tiny space, theoretically, this vasculature can get compressed. And that can cause problems later on. This is my resident doing that. Does everybody see that? The patient had no side effects, no problems. He followed this patient up for weeks. But to be safe and smart, it's better to stay away from the nerve. And the last thing I'm going to talk about, and I'm sorry that this is a year-long anesthesia course distilled into about 10 slides, is local anesthetic systemic toxicity. And this is essentially just, if you inject a lipophilic molecule into the vasculature, the two places it likes to go is your brain and your heart. If it goes in your brain, it prevents propagation of nerve signals, you see. And if it goes in your heart, it prevents propagation of nerve signals. It causes a widened QRS and defib. So again, the key is not to get it in there. To prevent that, we stay away from the nerve. And God forbid you do, we inject lipid emulsion. And I can give you that information later on. We've done it for 10 years and never had a case of it, but we always have this lipid emulsion kept in our pharmacy, kept in our nursing station, in our little plexus, our system, and we know how to use it. And really the anesthetic choice is key. So if you look at all literature on local anesthetic systemic toxicity, it almost always comes from bupivacaine. For our residents, we use lidocaine with epi because it's just safer. Lower risk, less chance for error. We've been lucky that we actually have a broad selection, our anesthesiologists work with us, of anesthetics, and we get to choose based on duration. And so for somebody who want to reduce a shoulder, I'll use a short-acting agent, reduce their shoulder, send them on their way. If there's somebody who has a deep abscess that's going to get drained and admitted to the surgical service, I may use a longer-acting agent. So I'm going to stop there, right? Too much information will only cause you guys to be like, I don't want to learn this. There is definitely a fear of too much, right? So I'm going to stick with 3 interesting blocks that are obscure, because that's the title of the lecture. I can't give you non-obscure blocks. Later on in the afternoon, we'll get very basic blocks, which I think you can go home and actually probably get done. These are a little more obscure because it's not as common, but I think are very useful. And I'll show you the utility of it, and you guys tell me what you think. This is called a superficial cervical plexus block, and it's something that we talked about The second is called the RAPTIR block, and I'll talk about that. This is, again, an advanced block for a specific situation. And the third is the serratus anterior plane block, and I'll talk about that as well. That block I love. We have now instituted that in our surgical program, so all rib fractures who come to our hospital get a block. And I'll show you how easy this is. There's Kian was one of our consultants. We were doing a course at SMAC in Dublin. I taught this block, literally just walking over and like, this is how you do it, Kian. He went home, he texted me, he's like, we just did 5 of these, they were wonderful. Like, I thought I was just teaching, I didn't really need you to do it. So I think it was a really useful tool, and I'll show you this block, and it's shocking how simple it is, because our interns now are bored by doing it, and they're like, oh, let somebody else do it, I've done too many of these. So there's not this superficial cervical plexus block. This is a little interesting block. We published a little series of this back in the day, I think it was 2010 or 2012, and the idea being that it's great for anesthesia for clavicle fractures. We have all these patients coming in for clavicle fractures. They'd fall down, they'd fracture, you'd give them pain medication, send them home. There was really no anesthetic choice. We had patients come in with neck abscesses, facial abscesses. We had no choice for this, anything below the mandible. And this was this nice little trick that's very easy to do with a 25 gauge needle and about 5 to 7 cc's of anesthetic. It's a really nice, fun little block. Again, this gives the anesthesia to this entire area, including the clavicle. It doesn't work great on the distal, but really for your clavicle fractures, this works wonderfully. We've done this numerous times, easy to do, and really great. This was developed for endarterectomies. So what's nice about this is it gives you this nice, deep anesthesia, and it's simple. It literally is simple. We started doing for central lines, for placement of central lines. It's just too much of a hassle to roll somebody to the side. But if your patient needs to be rolled aside and a central line, this is really, really beautiful. Because it's a very nice anesthetic when you're stabbing away at their neck. So clavicle fractures, these are wonderful. We block them, put them in a sling, start them on oral medications, and out the door. It's really fantastic. Let them follow orthopedic surgery. Facial abscesses that are below the mandible, like this young lady came in, this would have been a nightmare to get anesthetic for her. And you could use intravenous oral antibiotics or anesthetics, but really that's uncomfortable. What's nice is doing a little block. She's completely insensate, local anesthetic, open. She goes home and it's comfortable for 6 hours. She can start medications. So it's a beautiful little trick that people commonly don't use. So again, the linear probe, you guys know this, small amount of anesthetic. You don't need that much, and I'll talk about the planes. All you need is a 25 gauge needle. You don't need anything fancy. This is not a box full of anesthetic stuff. This is really simple. And again, you guys all know the basic anatomy. You guys know the thyroid, the IJ, and the carotid. You guys know this. And the beauty is, when you guys see the internal jugular and the carotid artery, that big muscle on top that's kind of triangular like this is a cervical. The beauty is, underneath that sternocleidomastoid, this little plexus comes out from deep in the nerves and innervates this whole area. So if I block that plexus, I put some fluid in that plexus plane, you're anesthetic, which is fantastic. So all I ask is start by the superior pole of the thyroid. You'll see the thyroid right here. And slide lateral. Once you slide lateral, you have that great little area. And you won't see nerves like I showed you before because this is a planar block. You will see this kind of thickening right here, but it doesn't matter. All you have to do is get underneath the cervicognastoid, drop in a little bit of anesthetic. And the beauty is you come back in 10 minutes, they'll be insensate. I will warn you, when you start doing blocks, this is my pet peeve, because I do it all the time. I block somebody, I'm finishing up, like, are you feeling better? She's like, no. I'm like, are you feeling better? No. They're like, you gotta go away. You gotta go get your coffee, you gotta go see another patient, and come back. Because you will drive yourself insane by asking them. But from this view, you have a really nice, all you want is a needle in plane to open the space up. The machine's always on the opposite side, because I want to visualize a screen. I don't want to do this. Nobody should be doing this with any kind of procedure. Central line, nerve blocks, joint aspiration. You always want to be ergonomically safe. Machine, visual field right here. So my movement is up and down, or even not even movement, just my eyes can move through it. You want your line of sight very clear, so the machine's opposite. Again, the needle's coming in this direction, and you can see the needle here is slowly coming in here and opening this space up. Push, inject, push, inject. That fluid is anechoic, will allow you to visualize that space. Again, there's your SCM, sternocleidomastoid. This is your IJ and your carotid. I've rolled the patient on the side, and I've started to inject. Pushing fluid as I go. Does everybody see that? Pushing fluid as I go. And I'll slowly push away this layer in this direction and stop. The beauty is this gives great pain control for what you need. Your clavicle fractures, draining that facial abscess. If you really want to practice doing central lines with it, it's fine. It's a nice, novel, obscure block that I think is really fun to do. I'm going to get a little detailed. I'm going to get really into the weeds on this, because this is something that I think is not easy, but it's groundbreaking for us. So this is something we published just recently, that we've been doing now for about a year and a half, and really has changed the way we deal with a certain injury. So who here sees bad distal radius fractures, Colles fractures? They're pain, right? There are many techniques, and I'm going to show you. Some people want to do procedural sedation, fine. Some people do hematoma blocks, fine. I'm going to tell you that brachial plexus blocks aren't perfect for the distal radius. I'll talk about it in the next lecture, but brachial plexus blocks are not perfect. We've tried various techniques to figure it out. It doesn't work that well. We've done hundreds of these, and they don't really work for the pain from distal radius fractures, from Colles fractures. This block works. I'll talk about it. So the reason we figured this out with a little help from our anesthesia colleagues was they would tell us, when we would go to these conferences, to do an axillary block. So what's beautiful is the axillary artery comes out here, and all the nerves run right around it. So you go right next to the axillary artery and put some anesthetic. The anesthetic will track around, give you essentially a spinal of the arm, which is great. And you can block that. And you can manipulate, position, splint, go home. Perfect. The problem was, when somebody has a really bad distal radius fracture, the last thing they want is some doctor to walk up and be like, move it out to here, ma'am. And then, when you come in, you have to come in really steep. So the two things I don't like. One is manipulating my patient. They should be in their comfort position. And second, steep needles are hard to see. This is kind of the old way of doing it. You're coming in this weird direction. This is a little more distal, but classically you come in over here, which is very difficult for me. Right? This is the patient that nobody likes dealing with for anesthesia. And I don't know if do you guys do your own reductions on this, or do you guys follow orthopedics? You guys do your own, good, good. So this is a pain in the butt for me, right? Because sometimes you just don't get good anesthesia, and the limitation for me to really pull on it is anesthesia. If there's no anesthesia issue, and I'll show you my patient at the end, I can pull away and really set that bone the right way. So this is just a vascular schematic, but I want you to understand the concept that the axillary vein, axillary artery, and all the nerve cords come out in that direction. Come from your neck, come out to the arm. This is the classic way of doing this, and you're like, what am I looking at? What you're looking at, remember the axillary arteries coming out from this and coming down this way? You're getting a cross section of the axillary artery. The old way was to go below the clavicle come very steep, and inject anesthetic here, right next to the artery, and hopefully get a big fluid ball right there. To me, that was scary. I just didn't want to do it. I did one of them, I didn't like it, it was uncomfortable, I was scared the whole time, I couldn't see my needle, and I didn't like it. A Brazilian group wrote a case series of 3 or 4 of these that was efficacious. So we said, I bet you this would work. They did it for something different. I bet you this would work for Achilles fractures. So instead, I'm coming in completely flat above the clavicle, dropping my needle in, and putting fluid right here. Does everybody see that? This allows my patient to keep my arms straight and have a nice, perfect vantage point. Start immediately, find the axillary artery, slide laterally into the delta pectoral groove, drop your needle flat, come right in. And you can see here, my machine will be right here. I have a great vantage point. I pop the needle in, I get complete anesthesia to the upper extremity. It takes about 5 minutes of my time. They're completely insensate, and I'm golden. Here's a schematic. Here's your clavicle here. This is inferior. This is superior. Does everybody see that? I'll show you some video. Does everybody see that? Okay. Again, same thing. There's my needle tip. This is my resident doing the clavicle will be right here. This is your pec muscle. This is your axillary artery. You're coming in underneath and depositing fluid right here. About 20 cc's of anesthetic. Again, obscure but very useful for us. Probably the only center that does this, but it makes a huge difference. This to this is done, which is so nice because you block them. I ask my techs to hang them. They put some weight. They get completely straightened. I walk up, I push, somebody puts a splint on, and I send them on their way. It's fantastic because it actually saves me time, even though it seems like it takes a lot of time. This young lady was a fallen outstretched hand. She had a distal radius fracture. She was a bad COPDer. Procedural sedation would not have been fun. She ate right before she came. This would have taken about 3 hours. And this is her post-op. If it plays. Oh, excuse me. Should play. And right now, we did this block about 15 minutes ago. I want you to tell me, I want you to move your arm for the audience so they know if there's any pain. No pain.
I can't even feel my
And so what's nice about this was complete reduction, post-operative or post-reduction pain control, and a novel way of taking care of our own patients that we would have given procedural sedation for. The last block that I think that all of us can take home to the bank is a serratus anterior plane block. I'm going to explain this based on basic anatomy. And I think this changes the way I practice medicine. It really does. So again, these are planar blocks. So planar blocks essentially is you're dumping fluid in a fascial plane and letting that fascial plane, letting fluid track up and down that fascial plane. When it does that, it provides anesthesia to the entire plexus, and I'll show you the anatomy. So we know this from thoracentesis. You guys all do thoracentesis, I'm sure. Right? You know that the nerve runs right underneath the rib, right? You hit the rib, you go above it. So the nerve runs right underneath. These are the anterior rami that come out from the spine, come around, and come in that direction, all the way out here. This is your anterior, the intercostal nerves that come out this way. If you look on your side, right, you have your latissimus dorsi, you have your serratus muscle right here, and your chest muscle. These nerves actually come around from the back, come over here, and then come out and sit right on top of your serratus muscle. So if I put the probe right where the serratus muscle is, again, the latissimus dorsi is right here, and the chest muscle is right here, This is that schematic. The nerves come out from the back, track around, come up here, and they become the lateral cutaneous branches at each level. If you find your serratus muscle and put anaesthetic in this space between your pec and between your latissimus dorsi, you now have a way to give somebody complete relief for their 4, 5, 2 rib fractures. The ones that are screaming in pain, I had a young lady came in, she was riding a motorcycle, fell off, broke 3 ribs. Intern and I did a block on her, and she's like, I want to go home. I had to convince her to stay because of her pulmonary contusion. She was so comfortable. And this is repeatedly happening. Again, these are your thoracic intercostal nerves. So again, if you think about this, we know your latissimus dorsi is back here, your chest muscle is right here, your probe goes right over the serratus, about the level of the nipple, in the mid-axillary line. Fine. Probe marker facing anteriorly. And you can see here, what you're going to see is, and I'll show you this without the schematic, latissimus dorsi kind of forms a little peak here. The pec major would be right here. This muscle sits right on top. This is your rib, and again, I'll show you without schematic. This is your pleural line. The goal is to get anaesthetic in this space, far away from anything that's dangerous. Does everybody kind of see that? So again, this is your serratus muscle. This is your latissimus dorsi. My goal is to get anaesthetic in this space. Once I get anaesthetic in that space, the person does all the heavy lifting. They breathe, and the fluid will track cephalad and caudate. So here is a representative video. Does everybody see that? Right? This is not really hard to find. It sounds, if I show it to you one time, you can find it. It's that simple. And the beauty is you can get away with thin patients with a 25 gauge needle. And if you just get fluid in this space, you've given them some relief, which before I didn't have any other mechanism. So again, the goal is to come into this space and inject anesthetic. And you can see on the model, same idea. Is that clear to everybody? So again, the beauty of this is your serrates, right? I've pulled off, this is the pec muscle, I've taken off latissimus dorsi. Here's your serrates. If you inject fluid, and there's studies where they injected radiolabeled dye into that space, fluid, as they breathe, tracks cephalad and caudate. So it gives a nice planar block of the entire chest that can be done at the bedside in about 5 minutes. And again, same idea, right? Each of those is a level.
Do you find it works regardless of where the rib fracture is, anterior, posterior?
So that's a level of contention. And we published another series. There's another group from our department that uses this thing called the ESP, erector spinae block, which is farther back for posterior rib fractures. It works better. People argue back and forth. And just to be a real nerd on this, this is the anterior rami, and there's a posterior rami that comes off of it. Theoretically, by doing the erector spinae block, you get the posterior rami as well. The problem with that block is a little more difficult. It's not hard. This generally works for anything lateral, probably from your latissimus dorsi and around the front. The posterior ones, it doesn't work well. We had one of our nurses rock climbs. You can only happen to an hospital, right? Falls down, has a posterior rib fracture, and she wants to continue working. So she comes into work every morning. Before work, 2 of us block her every day. This is only in our hospital, right? So she's very happy with this because she can't work, and she's she gets paid by daily shift. So we block her every day, and we're like, do you mind if we practice on you and try to figure out which is the right block? She's like, yeah, go ahead. So we're doing these great blocks on her, and she loved it, and it was the erector spinae block was working better. That was just published probably like a month or 2 ago. If you want a copy of it, I'm happy to give it to you. It's a little bit more difficult because you have to find the transverse processes and bounce off of it. which people get very fearful of. That's why I don't talk about it kind of in a, and plus we've only probably done about 30 of them. We haven't done the hundreds that we've done on this. So again, here's that same video. You guys all see it? You guys see the muscle? Here's the rib, it sits right on top. The needle's coming in, and you're gonna actually pop into that space. A couple things I always talk about is I always tell people to go through the fascial plane. As you pull back, inject a little bit of normal saline. Because what you'll do is you'll see that forward spread. You'll see the spread going in this direction. That means you're in the right spot. If you inject and you're not in the fascial plane, it'll stain the muscle. So you can see here, right, they pull back, and now they're injecting the anesthetic. I use normal saline to hydrodissect. Just a term, just use give anesthetic, or give volume to open that space up. So I know this has been kind of 3 interesting blocks, maybe make your mind spin a little bit, but the goal is really just to think about pain management in a different way. And I say this with all honesty. I think when I'm an active member in my patient's pain management, rather than writing an order of morphine, PRN, Q 20 minutes, I actually take an interest in thinking about what's going on and actually try to take care of it. I think it gives me so much joy to have people thank me for taking care of something that is so innately horrible, such as acute pain. It changes the way I do anything in medicine. It really does. And I think that really blocks work on the department you work in, right? You work at Harvard, and they don't do, they have an anesthesiologist come down to a regional block in 4 minutes for your hip fracture, then call them, but make them do it, right? If you work by yourself in a remote hospital, and there's a young man that needs to be transported 7 hours for a horrible hand injury, right? You gotta learn to do blocks. Questions?
I'm interested whether you've done any looking prospectively at your patients in terms of chronic pain syndromes, because we know that there's a proportion of patients who are going to get chronic pain syndromes from these horrible injuries.
Yeah.
It makes sense to me that if you're actually providing a nerve block, you're going to reduce your risk.
So this is a great question. So do nerve blocks prevent chronic pain? So if you look at the early literature from the Iraq War, they were doing femoral nerve blocks in the field. They were trying to get the blocks up front. They call it a wind-up phenomenon, and I can't do the entire intro lecture, but the wind-up phenomenon essentially is you, God forbid, break your leg right now. You have this humongous stimulation, right? Sympathetic, central nervous system stimulation that causes such severe pain that you are almost sensitized to pain next time. And by blocking that pain up front, acutely, in a really aggressive manner, you may prevent long-term chronic pain. And I completely believe that. The military data says that. But for us, it's really hard, and the benefits of being in the place I work is I get to practice some amazing medicine with some amazing people. The downsides are, if you call about 30% of my patients up, like, hey, how are you doing? They're like, this is a wrong number. You reached a wrong number, right? So there's good and bad. So I think that yes, we started this process, and Kaiser picked it up, and Kaiser has about $5–10 million initiative. Kaiser's a large HMO group in California that really does manage care well. And they've done a protocol now, based on our studies, that all their patients with fractures of the hip get a block, either by anesthesia or EM. And they're looking at this data. And I think it's really profound. And I think this is exactly what you're talking about. I mean, we have to be active members. I'm an acute physician. I'm an acute care physician. Nobody takes care of acute care like me. Acute care. If they're sick, they're hypertensive, I take care of it. Acute pain, that's me. It's not somebody else. I can't get that can down the road. Questions? Fox? Huh.
Yeah, you said hydrodissect
Yeah.
with normal saline.
Yeah.
And so walk me through that a little bit more. Like, so how much normal saline use, and then does that dilute the?
Yeah. So we do this commonly, and that's why I'm going to go back to this one slide that will make this make a lot more sense to you. This. So commonly when I have residents, this is really a nice tool with residents or new learners. So what I'll ask them to do is actually hold a needle, and then I will the first 10 cc's, I push normal saline because they commonly are not there yet. When they open the space up, then I push this up. So we call it hydrodissecting. There's other terms in the anesthesiology literature. But the goal is to really get to the right spot, because commonly when I was teaching new providers, they would get the needle and they would waste 6, 7 cc's in the soft tissue. So it's a really nice trick, and it's funny because I've used this. So I work by myself in a remote hospital far from San Francisco, where I get these patients that really get horrible care, horrible injuries, and everybody just does the same pattern recognition of I write pain medication, I sit down and look at Facebook. And I think it's unfortunate, right? And I think that what I've got my nurses to do is they actually will push normal saline for me as I hydrate. I'm like, push a cc, good, push a cc, good, push a cc. When I get in the right spot, I ask them, please aspirate, nothing in there. They switch the cap, they put on the anesthetic, and they push. And I think it's not a hard skill to learn. And it actually gives me the freedom and comfort of not having error.
Clearly you come with vast experience. Your training crosses over into what would be termed anaesthetics in this country.
Yeah, of course.
Teach them. So what you're saying is what I hear in anaesthetists when I teach them with other anaesthetists.
Yeah.
So not the average ED person is fortunate enough to get that sort of cross-training level. So how do you go about teaching yourself? Because clearly I'm not imagining that every ED physician in the States has that fortunate position of being able to get that skill set immediately. What did you do that sort of put you onto that path?
So I'll tell you that I think the easiest way to learn this block is to pick the block that is most relevant. And the femoral nerve block is something that, at least after 10 years of pushing this and hitting my head against the wall and publishing literature, seems to have gotten traction in the general EM community. Like they're, okay, the femoral nerve block I can do because now I'm supposed to, and that's part of my pain management. And opioids are bad, right? I mean, this is just the monikers that we use to allow us to work. So I think that's a great place to start. And I think I call it the gateway drug, right? Because you will do a little, and you'll have that patient, and I can tell you stories. They're so vivid where people come to me. I had a young gentleman that got his hands stuck. He was picking vegetables, he was a migrant farm worker, and he degloved his arm. And I'm leaving a shift, and he's screaming, and I mean, I've never had a family member in that much pain, but if I was sitting next to my child, or my mother, or my brother, who was screaming in pain, and the doctor was giving them more Dilaudid, or more hydromorphone, and then shipping them off to another center, it would kill me. I went over, I performed a block, and his mother came up to me and started crying and saying thank you. I could not hear him scream any longer. So I think by doing those femoral nerve blocks and having your patients tell you thank you, I think the gateway drug will happen, and you'll be like, hey Arun, this is working really well. Do you have any other blocks I can do? Oh, the serratus block? Let me try that for my patient who's crying with rib fractures. And I think that slow building is fine. I think starting with femoral nerve block, getting comfortable with the needle, visualization, you'll get there. But it has to be a desire and active practice. It is not easy. Doing anything, if I teach the 80-year-old physician who did blinds and Clavians for 45 years of his career, or her career, to do ultrasound guide central line, it'll be harder. So I think it's just a part of us as clinicians. There are clinicians who want to change practice, and there are clinicians that want to check in and check out. And I don't think people here see them like that, because they're here.
Just quickly, you talked about managing acute pain, but obviously we do hang our patients off other services. I wonder whether you ever use or obtain use of nerve block catheters.
Yeah, so we have used nerve block catheters. You published a series on this, and they're great. And for hip fractures, are perfect, right? To go in, it'd be a sterile procedure. We would hydrodissect, open the space up, slide the catheter in, and they have a simple little tool. It's really easy, and when they're done, they just yank it out. Our hospital, again, the benefits of my hospital is that we have a very advanced ER, or emergency department. We have a very unionized nursing force that will not allow us to do many things. We've got a new chairperson from anesthesia, and that's changing, so we're going to start putting catheters in. And I think it's a really great thing. And I think that is just something like anything else. It has to have a little bit of work. And I mean, literally, these catheters, we told them, we'll put them in, completely sterile. all you have to do is ask the patient to pull it out, because at other centers, they send them home with catheters, and they just pull it out themselves. And the nurse is like, no, we're not, you know, it's not part of our whatever. So I think it's a fairly simple thing. I think, again, this is the beauty of that initial slide of us hanging out with our anesthesiologist, is that this is great communication. Our surgeons ask us for advice.
We might wrap it up there and invite Elisa to talk about violent